All right, that trauma phone is ringing. You've got maybe 5 minutes before they hit the door. Let's make every single second count.
First piece of info from the pre-alert, it's a stab wound to the neck. Right away, your brain should be lighting up with all that critical anatomy. We're talking carotids, jugulars, the trachea, the esophagus. Everything's in play. And then the next bit of info drops. They're unstable. GCS is only 9. Okay, so this is not a sit back and wait kind of job. This patient is critically unwell.
So that's the pre-alert. The clock is officially ticking. Let's get our heads straight and break down what we need to do right now.
Okay, let's start with the neck. Everything you do, every thought you have in these first few minutes boils down to one massive question. Does this patient need to go straight to the operating theater, or can we get away with a trip to the CT scanner? So the very first thing you need to figure out is simple. Has the wound breached the platysma? You got to think of this thin sheet of muscle as the gatekeeper. The moment it's violated, you have to assume there's a significant underlying injury. It's no longer just a superficial laceration. It's a gateway to a whole world of trouble. And this slide, right here, this is probably the most important fork in the road. If you see any of these hard signs, we're talking active bleeding, a hematoma that's getting bigger right in front of you, shock, or a compromised airway, that is a one-way, non-stop ticket to theater. Do not pass go, do not collect a CT scan. Soft signs? Yeah, they buy you a bit of time to investigate, but hard signs mean you move. Now. Got active bleeding? What do you do? First, simple stuff, direct pressure. Put your whole hand on it, don't be shy. If that's not cutting it, grab a Foley catheter, stick it in the wound track, inflate the balloon, and pull some gentle traction. It's a fantastic little trick for tamponade. But look, these are just temporizing measures, right? They're just bridges to get you to the definitive fix, which is always in the operating theater. All right, let's shift our focus down to the chest. Your job here, in that primary survey, is to find and fix the 3 absolute killers of penetrating chest trauma. Fast. And when we talk about the chest, we have to talk about the box. This is prime real estate for catastrophic injury. Any wound inside this area, we're talking clavicles up top, coastal margins down below, and nipples on the sides, you have to assume it's hit the heart or the great vessels until proven otherwise. Your index of suspicion for any wound here has to be through the roof. First up, killer number 1, the tension pneumothorax. It's basically a one-way valve that just keeps pumping air into the chest, and it will kill your patient if you don't act. So, picture this. Your patient is struggling to breathe. Their blood pressure is tanking. And you listen to their chest, and there are no breath sounds on one side. What is your very next move? What are you doing right now? The answer is you decompress immediately. You don't ask, you don't wait. You do it with a big cannula or, even better, with your finger. This is a clinical diagnosis. Let me repeat that. Do not wait for a chest x-ray. Waiting for imaging is a fatal mistake.
All right, on to killer number 2, cardiac tamponade. This is where a tiny bit of blood gets into the pericardial sac and literally strangles the heart, stopping it from pumping.
Now, for your exams, you absolutely have to know Beck's triad: hypotension, muffled heart sounds, raised JVP. But, and this is a big but, in the real world, you'll only see that classic triad in maybe a third of cases. So what's your best friend? It's that bedside ultrasound probe. An EFAST exam is going to give you the answer way more reliably. And that brings us to killer number 3, the massive hemothorax. This is just straightforward catastrophic bleeding. The patient is literally bleeding out into their own chest. So you put in that intercostal drain, and then it's all about the numbers. If you get more than 1,500 mils of blood out straight away, or if you're consistently getting more than 200 mils an hour for a few hours, that bleeding is not stopping on its own. That's your trigger. That patient needs a thoracotomy, and they need it now. Okay, so we've dealt with the holes in the neck and the chest. Now we need to zoom out and look at the whole system. We're talking about damage control resuscitation. The goal here is simple: stop the patient from bleeding to death. And at the very heart of this is the lethal triad. You've got hypothermia, acidosis, and coagulopathy. The scary part is they all feed each other, creating this downward spiral of death. You have to attack all 3 of these things at the same time, aggressively, or you will lose this patient. It's that simple. So how do we tackle that coagulopathy head-on? Well, it all starts with a very simple, very powerful ratio. 1 to 1 to 1. 1 unit of packed red cells, 1 unit of fresh frozen plasma, and 1 unit of platelets. We know from the proper trial that this kind of balanced resuscitation directly fights the coagulopathy of trauma and, most importantly, reduces the number of patients who bleed to death. The takeaway? Activate your MTP and activate it early.
And while we're talking about bleeding, please do not forget your tranexamic acid. The benefit here is huge, but it's incredibly time-sensitive. We're talking a 32% reduction in death from bleeding if you get it in within that first hour. But wait longer than 3 hours, and you might actually be causing harm. The message couldn't be clearer. Give TXA pre-hospitally if you can, or the second they roll through your recess bay doors. Okay, let's pull all of this together. We're going to wrap up with the absolute critical interventions and those high-yield pearls that you need for the floor and for your exams. This is probably the biggest, most high-stakes question in any trauma resuscitation. When do you actually crack the chest? Let's get really clear on the indications for a resuscitative thoracotomy. Now, the indications for this are incredibly strict, so listen up. This is only for penetrating chest trauma patients who've just arrested and, crucially, they had signs of life within the last 10 minutes. Or it's for the patient who is actively dying, losing their pulse right there in front of you. This is a Hail Mary procedure, for sure, but it can work, but only if you pick exactly the right patient.
All right, let's do a final rapid-fire rundown. Takeaway number 1, in the neck. Platysma violation is your key threshold. Number 2, hard signs equals a straight shot to theater, no imaging detours. 3, a wound in the box means you need to be worried about the heart. 4, get that TXA in early. The biggest bang for your buck is in that first hour. 5, in a massive bleed, you're targeting a fibrinogen over 1. And finally, number 6, embrace permissive hypotension, let that SBP ride around 80 to 90, unless, and this is a big unless, there's a concurrent head injury.
And that is a whirlwind tour of the first 5 minutes of penetrating trauma. So, what's another high-yield EM topic you want to see us break down like this? Drop your suggestions in the comments below. And hey, if this was helpful for you, whether it's for your next shift or for your exam prep, do us a favor and hit that like and subscribe button for more content just like this. Stay sharp out there.